Hello, everybody. This is an announcement about the study time with the professor. I'm going to do it Monday, which is this coming Monday. Normally it's on Tuesdays, but I'm going to do it Monday at 6:30 Eastern time. Also, I have posted links down below for anyone that is needing some extra information on the anti-infectives and the psych drugs. So click on the links below to get the information for anti-infectives and psychotic drugs or our psych meds. So just a couple of things. So when you click on the link, it's going to take you to a Google Drive. So it's on my Google Drive, but as long as you have the link, this access to the link, you'll be able to click on it and view it. So feel free to share it with your fellow nursing students. Once again, we will have a live, instead of Tuesday, we're going to have it Monday for the study time with the professor. So bring all of your questions about any drugs that you may have. And I will talk a little bit about psych drugs and anti-infectives, but remember, I don't like to keep the study time with professors too long, because then it starts to wear on you. Just a few things about the resources that I'm posting down below. So anti-infectives include antibiotics, antivirals, and antifungals, and your anti-TB drugs. So when you say anti-infectives, you're really talking about all of those. Anything that causes bacteria, fungus, or the TB infection. My brain went blank there, but fungus, bacteria, virus infections, and the TB infection. So when you're talking about antibiotics, there are subclasses of antibiotics. So you have your sulfamides, your penicillins, your cephalosporins, your macrolides, your quinolones, aminoglycosides, and tetracyclines. These are your antibiotics. So when you're thinking about antibiotics, think, when I'm giving a patient, a client, antibiotics, I'm giving it to them because they have some type of bacterial infection. So the mode of action for all of those drugs is going to be getting rid of the bacteria, right? Whether it's killing it, inhibiting it from growing any further, whatever the mode of action may be. So the mode of action with these drugs, we're talking antibiotics, may not be that important, because in one way or the other, it's there to do something to the bacteria. It's in there to destroy it, right? Some way or the other, whether it's destroy it from growing anymore, destroying it from growing, period, whatever it is, okay? So you're going to think first about your classic signs and symptoms of the patients. If I have a bacterial infection, that means I have something foreign growing in my body. If something is foreign growing in my body, then, and you know what, let me share this. Instead of you just looking at a black screen, let me share this really quick. Sorry for the interruption, but let me, okay. Let me share this. I don't want to just talk with a blank screen. Okay, and this is the resource that you're going to get. So when you're talking about antibiotics, you don't just want to look at the drug. You want to also look at the signs and symptoms of the patient, right? So what are some things, no matter what, a client or patient would come in or present to the doctor's office, urgent care, present at home if it's home care, present in the hospital, right? They would present with probably a fever. They might have some malaise, so they might be feeling weak and tired and just not feeling well, loss of appetite, And that's because bacteria is a foreign entity, right, in our bodies. It tells our bodies something's in me, right, that shouldn't be. And I tried to get rid of it, right? Remember, we always talk about the compensation. Go back to your patho. Your body's beautifully made. It's made to fix everything. So we go back to the patho. It's trying to kill it. It's trying to fix it. But if that bacteria is too strong, it's taking up some steam. It's growing a little too long in the body. The body says, okay, wait a minute. I can't do this anymore. I don't know what to do with whatever this is in my body. It's something foreign. I don't like it. So I'm going to heat up to kill it. There you have your fever, right? Go back to patho. If you don't understand this, go back to your patho. So your body's heating up to kill it. So having a low grade temp is actually okay because it just means our body's trying to kill something. It's trying to work something out. But it's when that fever gets a little higher, we add in a little nausea, maybe a feeling of malaise. I'm just so tired. I feel weak. I can't eat. Something's not right. Yes, I've had this fever for a day. That's okay. But now it's been a couple of days. The fever's getting higher. I've been taking acetaminophen, AKA Tylenol, or I've been taking ibuprofen, AKA Motrin, to try to get rid of this fever that I have that I don't know where it's coming from. And it's not working. I've been taking it round the clock, couple of days, and the fever, yeah, it'll go away, but then it comes right back. That means this bacteria needs some help being murdered, okay? Sorry for saying that word. Killed. Okay, I can't say that word either on YouTube. We're trying to get rid of it, okay? We're trying to get rid of the bacteria, okay? That's what we're trying to do. We're trying to get rid of the bacteria. So that's why you have the signs and symptoms. You end up going to, like I said, doctor's office, urgent care, hospital, for the ER, whatever it is. They run some tests because that's what we have to do. So if you don't have an active, wound where we can see that it's infected and you're just feeling like this, then we need to do some type of cultures, whether we take some blood, send out blood cultures, whether you have signs and symptoms also that mimic a urinary tract infection. So then we'll have you, urine in a cup, send that off to the lab, whatever it is, whatever your other signs or symptoms, that will give us the direction to go in to see what we need to do to send off something to the lab, right? Whether it's blood, urine, sputum, whatever it is, right? So we send that off to the lab and we get our initial, yes, white blood cell count is high, so there is an infection. Yes, we did our initial dipstick test into the urine and it showed there's some bacteria in there, okay? And then we send it off to the lab to be cultured. Now we know that the culture, whether it's blood, urine, sputum, will take a few days, right? So we won't know exactly what bacteria it is, but we can give you a broad spectrum antibiotic until we find out what it is. Some of your broad spectrums are your sulfamides. Penicillin can be a broad spectrum. They don't usually use it as a broad spectrum, but it's also a prophylactic. Like if you're going for surgery, you may see somebody on a cephalosporin or a penicillin. Sulfamides, that's your broad spectrums that you'll see most of the time, okay? And I'm just loosely talking about this. This is all in the slides that you'll get access to, okay? I'm just giving you a broad overview of antibiotics. Because when you study this, what I want you to do is focus on, now listen to how I say this, focus on sulfamides. What names of drugs are in sulfamides? Okay, then from there, I want you to say, okay, what are the common adverse effects of sulfamides? Now, I don't want you to say nausea, vomiting, diarrhea. I don't want you to say that, okay? Because nausea, vomiting, diarrhea is for every last one of these you see on this screen. Every antibiotic, nausea, vomiting, diarrhea. Why? Because it's a medication that's going inside of you to kill something. So it's disrupting your body, and it could even be killing good bacteria. So yeah, absolutely, it could cause nausea, it could cause some vomiting, it could cause diarrhea, because it's just in there messing up stuff, right? So we don't care about that. Nausea, vomiting, diarrhea, you're going to answer that question every time. You'll get that one right, right? Because they're drugs, they're chemically made, they're in there killing stuff. I know I'm going to have that. I don't want to study that. What I want to study are some specifics for sulfas, like Stevens-Johnson syndrome. That's something you would have to read to know. That's not just an automatic, oh, Stevens-Johnson syndrome, every drug causes that. No, every drug does not cause that. So that's specific to sulfonamides and some other drugs, but we're talking about antibiotics right now. Okay, so again, you take the subclass sulfonamides, then you take what drugs are in that subclass so that you are able to recognize them, right? Look at the prefix and suffix. And for these drugs, sulfa is the suffix, right? The prefix, I'm sorry. Sulfa is the prefix. It's somewhere in the name, okay? So whenever I see a drug that has the word sulfa in it, it's a sulfonamide. So I automatically know nausea, vomiting, diarrhea. I know that. I automatically know it's killing some type of bacteria. I automatically know Stevens-Johnson syndrome is a potential adverse effect. Now from there, you take, what are my nursing considerations? Now here's the beauty of antibiotics. All of these have pretty much the exact same nursing considerations. And then each subclass may have a special thing that you look out for, okay? So for instance, all of the antibiotics nursing considerations are: patients should drink lots of water. We should not start the antibiotics prior to sending off labs, right? Where there's urine, sputum, blood, right? We already talked about that. It could be photosensitivity with all of these. So patients want to be careful. If they have diet, now we know diarrhea is a potential adverse effect, but if you have diarrhea more than a couple of days, you need to contact the provider. So that's something we want to teach them about. Okay, so these are, and you'll see some more of these on the slides, but these are just some basic things that are nursing considerations. So let me break it down. Antibiotics, they have subclasses, which you see on the screen. You're going to write down in your notes, subclass sulfonamide, list the name of the drugs in that subclass, and then write down or highlight in yellow or pink or circle what the prefix or suffix is, so that whenever you see a drug with that prefix or suffix, even if you've never seen that drug before, you know, oh, it has the word sulfa in it. It's a sulfonamide, okay? So recognizing the names of the drugs in this subclass. And then what are the adverse effects for this subclass that stand out? Not the nausea, vomiting, diarrhea, no. What stands out, like Stevens-Johnson syndrome, okay? And then nursing considerations. So if I were you, before I even go deep into the subclasses, I would write the top category, antibiotics, and then write down all of the common nursing considerations for all of them. So then when I'm talking about sulfonamides, all I need to know is there anything specific I need to tell my patients when they're taking a sulfonamide, right? And then the last category, and you probably have a template that talks about this. If you don't have the template that kind of maps this out, I'm going to also post that in the link down below. Like I said, the link is going to take you to a Google Doc. But the last category is, who takes this medication? Who would the provider put on a sulfonamide? Is it someone that needs a broad spectrum? Remember, we just talked about that. If a patient has a urinary tract infection, or really any type of bacteria, but we don't know what it is yet because we send it off to the lab for a culture and that's going to take a few days, then I need to put them on something because we need to start killing this bacteria. We don't need to wait. We need to start killing this bacteria now before it gets worse. So you always put a patient on most of the time, you're going to put them on a broad spectrum. Okay. I can't speak to what every provider will do because some providers just, boom, they know what it is. They're going to put you on that right away. Even when the cultures come back, they're going to say, I knew it was that, stay on that drug, right? Whereas sometimes we don't know as providers. I'm not a provider as far as a physician, but sometimes providers don't know what to prescribe. So they'll put you on a broad spectrum. And then when the cultures come back, they'll say, okay, it's this. So we're going to switch your antibiotic. Stop taking that one. If you took it this morning, that's fine. We're going to send the new one to the pharmacy. And then tomorrow, pick it up today. And tomorrow you'll start on the new one for 3 days or 7 days or whatever. Okay. That's how broad spectrums work. So again, write down antibiotics as your top title. Put down all the common themes that go along with all of the antibiotics, okay, which is nausea, vomiting, diarrhea, right? Your nursing considerations, that would be for all antibiotics, and then take them and do them in chunks. So take sulfamides, say, okay, let me write down all the sulfamides. Let me put the prefix and suffix, even if I don't want to write down all of them that are in a book. Maybe I'll write down 2 or 3 of the most common ones. And then as long as I'm able to recognize the prefix or suffix, if I were to see that drug again, I got it. Because even though I didn't study that particular drug, doesn't matter. It's in that class. It's in that category, okay? That subclass. Your adverse effects that are specific to that subclass, and then any nursing consideration that's specific to that subclass, and then what would a client or patient be taking that particular subclass for? So that's how you break it down. Same thing with antivirals, antifungals, and then your anti-TB drugs, you're mainly just going to focus on your INH and your rifampin. And you're going to write down the adverse effects for both of those because they have specific things that pertain to them. Once again, I'm going to answer any questions you may have in the Study Time with Professor podcast on Monday at 6:30 p.m. Eastern Time, but you will have access to all of the resources for all of these drugs I'm talking about. Now, psych drugs. Psych drugs break up into certain categories. So there are anti-anxiety meds, there are antidepressant medications, there are antipsychotics, and there are mood disorder drugs. I'm not showing this on the slide right now because I don't want to pull it up, but you'll have all of the resources to those. Let me go back so you're not looking at these. So when it comes to psych drugs, you treat the issue. What is the issue that the client or patient is having? Are they having some anxiety? Is this a temporary anxiety? Is this something they've been suffering with for a long time? So they're going to have to be on a long-term med. You cannot put people on benzodiazepines long-term. And I know what you're about to say, but I know a few people, or I know someone, or my family member has been on, and I'll say the trade name, Xanax, okay? But the real name that you're supposed to understand and remember is alprazolam, okay? So if you know someone that's been on alprazolam for a long time, that's not good. Benzodiazepines are not meant to be long-term medications. So what you'll find for patients that have long-term anxiety is 9 times out of 10, they probably have some slight depression. So you'll see that the provider will put them on an antidepressant medication. Okay, so your benzodiazepines and your barbiturates are meant to be short term, whereas your antidepressive medications like your MAOIs and your tricyclics, which both of those are outdated, antiquated, and they have lots of adverse effects, both of those classes of depressant drugs. So oh gosh, it just escaped me. The other class of antidepressants, and I can't remember it right now, the other class of antidepressants, you know what, I'm going to pull it up. The other class of antidepressants, let me pull it up. The other class of SSRIs, how could I forget that? Oh, SSRIs are better because they have less adverse effects. Now, they still have adverse effects, right? But they have less adverse effects than most of the other drugs, like the MAOIs and the tricyclics. As a matter of fact, I had a family member that was going to put on a tricyclic, okay, for migraine headaches, because yes, it could be used for, oops, went to the wrong one again, migraine headaches. And I advised against it. I said, absolutely not. Tell your provider, and I'm not a provider, but I said, tell your provider to give you something else, because no, that tricyclics have lots of adverse effects, and one of them is dead. Okay, that's the adverse effect, is dead. Okay. For those students that have had me, you know what I mean. Okay, so SSRIs are better for long term. So they're good for depression, because a lot of times depression is long term. But you also see on this slide, it says anxiety, panic attacks, OCD, bipolar disorder, obesity, yes, eating disorders. SSRIs help for a lot of things. Now, they do have adverse effects. They are chemically made drugs. So dead, right? No, they don't kill you. I mean, oh gosh, I'm saying so many words that YouTube is going to get me. All right. So they're not as dangerous. Okay. But you know, they're still chemically made, right? In a lab. So of course they still have adverse effects, and they could cause serotonin syndrome, which could lead to something dangerous. So as long as patients take them, or clients take them as directed, that's a big nursing consideration for your psych drugs, all of them, whether it's the short-term benzodiazepines, the long-term antidepressants, the long-term antipsychotics, is education, education, education. You have to teach clients how to take these medications and what not to do, because abruptly stopping them could cause problems. Overdosing on them, meaning, oh, this isn't working, let me take another one. That could be a problem. Sometimes they take a week or two to even work. So when a patient is given them for the first time and it's been a week and they're like, I'm still depressed, this isn't working. Suicide is a big issue, because they're thinking nothing works for me. So this is not going to work. I've been taking them for a week and it hasn't worked yet. So this is why, you know, sometimes they commit suicide. So it's very important that we educate our clients when they're on antipsychotics. I know we flipped from antibiotics to antipsychotics really fast, or psych drugs really fast. But these are the resources that I'm going to be linking down below. Again, bring all your questions about all anti-infectives or your antipsychotics. If you have any questions about other drugs, bring them all to the podcast, Study Time with the Professor, on Monday, this week only, Monday. All right. See you guys later.